You're watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. Today's topic, new treatment options for people suffering with glaucoma. So if glaucoma runs in your family, or if you've been diagnosed with glaucoma, or if you have any of the symptoms we're talking about today, you're going to have to listen to what Dr. Ling Bei has to say. She is a fellowship-trained glaucoma specialist, a board-certified ophthalmologist, and Dr. Bei, welcome to the program.
Thanks so much, Randy, for having me. I appreciate the opportunity to talk about glaucoma.
Now, for people that don't know your centers, Acuity Eye Group, who's the typical patient?
So we actually see the whole gamut of all patients from all ages throughout Southern California. Acuity Eye Group is actually the 4th largest eye group in the entire country.
Okay.
And we're really fortunate because in California we have so many different centers, which allows patients easy access to any of our centers, basically from Northern California all the way almost down to Mexico. We really pride ourselves on the fact that we're efficient. We have the latest technologies, and we have some of the, we think, the best trained physicians, optometrists, and other practitioners within our group. Our goal is to really let patients have easy access to us. We have 24-hour on-call doctors, and we have every subspecialty within ophthalmology. So many people don't know that even within the eyeball, there's about 6 or 7 different subspecialties. We see everybody from little children, kids from 3 or 4 years old, all the way up to anybody who's in their 90s. And I've actually had a 102-year-old patient I've seen for several years. Yeah.
Now, you know, my father, and how I know about you, because my father, you know, we looked up who's like the best of the best, and my father had his cataract surgery with premium lenses, so now he could see distance and up close, and he's 82 years old.
Right.
And according to him, his whole life has changed.
Right.
But so with your role in the center is what? Because all you do is glaucoma? Because you guys treat everything, right?
We do. We treat all subspecialties, but my primary focus and my love is really glaucoma. And glaucoma is a subspecialty within ophthalmology, and I certainly do cataract surgery, but my main goal is to see those patients with chronic glaucoma.
Now, we talked on the phone. You said early on, I mean, you knew in medical school, you wanted to focus on glaucoma.
Right.
Why?
So it's funny because everybody who goes into ophthalmology, many of the people say that glaucoma is the most challenging thing, and it's really challenging for 2 reasons. One is that people still to this day, from a scientific point, don't really understand why certain people get glaucoma. And some people look at that ambiguity and say, it's something I don't feel comfortable with my patients discussing or treating or following up on. But I really look at that as a challenge. I look at that and say, this is an opportunity where we're really on the forefront of trying to understand a disease. And our patients are our partners in trying to figure out what are the best treatment options. The glaucoma patients I have are some of my most loyal patients. I've seen some of them for 10 years, so I started with them early in training in San Diego, and then as I finished, they actually followed me to my practice in Orange County. So I see these people 3-4 times a year, and I've really built long-term relationships. I think that's really unique in ophthalmology. There's a lot of specialties in ophthalmology that don't get that opportunity to have that long-term, unique, trusting relationship with the patient.
Now, with glaucoma, and you're a glaucoma specialist, do you need a referral from your regular ophthalmologist or optometrist to see a glaucoma specialist?
That's a great question, Randy. So the good thing is that you actually don't. I mean, patients, we love it when our patients call us and say, hey, I just want another idea. I just want a second opinion. I heard this. I wasn't sure if it was true. Could I come by and just get another opinion? We love that idea.
Are there many people that have glaucoma that have never seen, that means they're under treatment, maybe with drops only, right? Are there many people that have never seen a glaucoma specialist and they have glaucoma?
I would say the vast majority,
The majority.
Just like you said. So many patients with glaucoma, they've had it for years, or maybe they've had a questionable diagnosis with an eye provider for years, and they just say, well, I know this eye provider, they're local to me, it's hard for me to get out to X, Y, and Z city to see a glaucoma specialist. And they don't realize that with our group, you really have one in your backyard most likely.
And Medicare covers this, right?
Medicare covers it. So it's not something that requires a lot of hoops and hurdles and authorizations. You can just talk to your primary care doctor if you have an HMO, but if you have Medicare, you can pick up the phone and actually call yourself.
So how big of a problem is glaucoma? I mean, how many people? Are there estimates of how many have it?
So we actually know that about 20 to 30 million people in the United States have it, which is a really huge number of people who are underdiagnosed. They've actually done studies that about 50% of people, half of all people have glaucoma, by the time they get to an eye doctor, they've already lost vision. So that's a really high percentage, and we want those people to come in sooner.
What are the symptoms and what is glaucoma?
Sure. So glaucoma, think of it as kind of a plumbing issue. So if think of it as just something as a plumbing problem. So if you think of your eye as a kitchen sink has a faucet and a kitchen sink has a drain. And the faucet is always on deep inside of the eyeball. So the faucet is always making water.
So this faucet is keeping the eye lubricated?
It kind of keeps the eye actually filled with water. So if you think of the eye as like a balloon, if you didn't have that water fill up that balloon would deflate like a raisin, right? You want that balloon to actually be inflated the whole time because that's what keeps the shape of your eyeball. And so think of your eye as that kitchen sink that's filled with water by the faucet. And in order for that eye to keep that round shape, there also has to be a drain to allow the water to leave the eye. And there's this constant balancing act, water in, water out. Now, for reasons we don't totally understand, some people's drains with time, aging, genetics, a lot of other factors can scar. It can get damaged through other procedures or through surgeries or through other diseases. And their drain actually starts to slowly become more and more sluggish. So the water that's constantly being made has nowhere to leave. And if it has nowhere to leave, then the pressure in the eye starts to build up as more and more water builds up inside of the eye.
Interesting. So people with glaucoma,
right?
And we've talked on the phone, you say some of them feel a lot of pressure on their eye. And you're saying, so it's a drainage issue.
Exactly. And a lot of people actually don't feel the pressure because strange enough, just like everything else in life, you can adapt to it. So they can have high eye pressures for many, many years and not even feel it and just think that this is just a normal sensation in their eye.
So when you get this pressure, what is happening to the eye? How destructive is it, I guess is my question.
Sure. So in the short term, glaucoma, high eye pressure, you would think that it shouldn't do any damage because maybe that drain can still flush out a little bit of that extra water. But over time, what starts to happen is that the water builds up more and more and it starts to squeeze on the nerve that connects your eye to the brain. So think of that nerve as like a toaster, for example. A toaster needs to work by having its wire plugged into the wall. The eye works the same way. The eye has a nerve, and that nerve plugs the eye into the brain. So if that wire doesn't work that plugs your eye into the brain, that optic nerve, then that eye and the brain aren't talking to each other, just like a toaster wouldn't work without the wire plugging it in.
All right.
So if that pressure in the eye starts to build up more and more, it squeezes on the nerve, and the nerve starts to slowly die, and that's the end result of glaucoma.
So the dying nerve causes what set of symptoms?
So the nerve itself, as it dies, for most people, they start to lose their far peripheral vision.
Peripheral vision.
Peripheral vision, exactly. Okay. And that's why it's very, very hard for people to even detect it. Because when you start to lose your peripheral vision, you're not really aware of the initial symptoms. You can do most of your tasks. You can read. You can watch TV. You can even drive. But you just know subliminally there's something not quite right. And over time, if that high pressure in the eye doesn't get treated and the nerve gets more damaged, you actually lose more and more and more peripheral vision until you see only a tunnel. And in the end stages, when that tunnel vision doesn't get treated with high eye pressure, the tunnel just completely goes away. We call that snuffing out, and that's irreversible.
Give me a rundown of the obvious symptoms of glaucoma.
So the most obvious symptoms that people tell me are they have a nondescript feeling that their vision is just not quite right.
Okay.
Their depth perception is off.
Depth perception?
Depth perception, exactly. So when they're driving, they may not feel like they know exactly how far to stop from the car in front of them because they don't know when to brake. That feels a little bit more uncomfortable. When they're driving, trying to park into a parking space, the parking space doesn't seem quite centered.
Oh.
They're hitting curbs when they're driving. People also tell me that they're having trouble, for example, like on their cell phone. They used to be able to see right in front of them on their cell phone. They could see the small print, but now there's this vague cloud over their vision that they just can't seem to shake out. And it doesn't change throughout the day. It's just always there.
What are the current treatment options and how have they changed? How have they progressed? I guess eye drops are the number one way it's treated?
Well, that's a great question too, Randy, because one of the big issues is we tend to see people think that eye drops are the only method, and that's actually becoming less and less true.
Really?
Yes. So just this year, actually, there's 2 new eye drops that are coming out. In 2018, there's 2 new eye drops that are coming out. But as I've seen in most of my patients, especially the ones who have had glaucoma for many years, they've actually wanted to go away from eye drops.
Why?
Well, think about the time, the cost, how you have to stop on your day.
So it's out of pocket to get these drops?
Yes.
Oh,
so even if there's coverage, the copays can actually be very expensive. Most of my glaucoma patients are now on generics, but even on generics, some of the copays are $20, $40 a month. And if they're on 2 or 3 eye drops, that's a big cost to a lot of patients. So a lot of my patients actually tell me, I don't really want to be on eye drops forever. I don't want to stop my day and look at my cell phone and say, hey, I got to run, I got to go home because my eye drop is sitting at home and I'm out to lunch.
These eye drops, so I understand.
Yeah.
You talked about the drainage of the eye. They help with the drainage
Exactly.
to relieve the pressure on the eye.
Exactly.
Okay.
So they act to turn down the faucet deep inside of the eye. So they either tell the eye to make less fluid deep inside of the eye by turning down the faucet, or they work almost like a Drano. What they do is they push open that drain to try to get more water out of the eye. And so those eye drops are very effective, but in terms of a quality of life issue, which we think is the #1 priority for our patients, they become more and more cumbersome the longer you take them and the more you have.
So what's the answer?
So the answer is what you come up with your doctor. You really want to come in with your doctor and say, this is working for me, this is not. I'm not saying that drops aren't for everyone, but as we have come into this new generation of new glaucoma technology and surgeries, we want to have patients know that there are many, many options now besides eye drops, including laser, including surgery, including microinvasive surgery. All of these are now on the forefront of new technologies that many didn't even exist or weren't FDA approved even 10 years ago.
Could we briefly go down one by one of those lists? So laser, how are you using laser to maybe get people off drops? And are there people that were taking drops and now they're off drops?
Yes.
Really?
Yes. So laser is so easy to do because it's not surgical, meaning you don't have to go to an operating room. There's no anesthesiologist. There's no recovery in terms of an eye patch. There's no cutting. There's no bleeding. You go to your ophthalmologist's office or your glaucoma specialist office, and you just come in, have the laser done, which is a contact lens placed on your eye for about 2 minutes. The laser is done without any pain, without any bright lights, without any discomfort, and you go home. My patients just drive themselves home because there's no anesthesia, no pain involved.
And what is the laser doing to stop, to do what the drops were doing?
Right. So the laser is actually going right into the drain deep inside of the eye. The laser basically pushes on the drain, helps the drain remodel. So by pushing on the drain starts to regrow, and when it does this regrowth, we hope that the drainage holes are actually larger than the initial ones. If the drainage holes inside of the eye are larger, that means that the water in the eye can leave more efficiently and drop their eye pressure.
And so they go in, this is like a 10-minute procedure?
Exactly.
They
really
go home,
5, yeah.
And they no longer have drops, in many cases.
In many cases. So if you're really only on one medication, about 70 to 80% of my patients can go off it by just doing the laser.
So now look, the reach of this program is more than 25 million people. So there's probably hundreds of thousands of people on drops that are watching this, right? Mm-hmm. And maybe is this something they know about? Like they've heard about laser surgery, maybe because it's got surgery attached, they're afraid of it? Exactly. Why aren't they all trying it?
Exactly.
Is my question.
Or
at least getting evaluated.
Exactly. Some of it is really just knowing that it's available. A lot of doctors have this idea that I want to try every single eye drop until they need laser. And laser is seen as a last resort. But a lot of patients don't need to think of it as a last resort. It can be used at any point. I've had young patients who say, look, Dr. Bei, I go to work in the mornings and my eyes are bloodshot red and my employees are asking me, why do you have such bloodshot red eyes? And they don't want to take the eye drops anymore. And they're in their young 40s and they just don't want the inconvenience or the hassle of putting these eye drops in. We can do laser off the bat. That is something that now we can actually do.
Is it cash out of pocket for the laser, or is that also covered by Medicare or insurance?
It's covered. It's completely covered by insurance because it's medically necessary.
Okay, good. So lasers work. Look into lasers.
Look into lasers.
If you've been diagnosed.
Yes, and talk to your doctor because not all doctors have access to the laser. The machines usually sit at a surgery center, so you have to go to a surgery center to get it. But ask your doctor what the availability and what their access is.
Okay, good. Next technology, surgery.
Yeah.
What is surgery doing?
So think about surgery as us creating another way for the water to leave your eye. If your own drain is not working, and we've tried different ways to either flush out the drain or remodel your drain, and your drain is still sluggish and not pushing that water out, we have to basically create another artificial way for the water to leave the eye. So about 20 years ago, everybody was doing these big, I would say more invasive surgeries, meaning you have to go to a surgery center, the surgery is about an hour too long, we're creating artificial holes in the wall of the eye, we're covering them with stitches, there's going to be laser involved afterwards. Often there's a recovery of maybe 1 or 2 weeks, and you're going to see the eye doctor maybe once a week for about 2 months. Those are pretty hefty commitments for a lot of patients. And today now we have what we call microinvasive glaucoma surgery, or MIGS, and we have the latest technologies now that we actually perform during surgery. You still have to go to an operating room. there's a lot less cutting, there's a lot less bleeding. We can put small stents into the eye, and basically the stents bypass your own drain and create a new, totally different drain. So think of it as maybe if you're stuck on the highway, and gosh, we know because we're in California, if you're on the 405 and there's no exit, you're just stuck, just like the water deep in your eye has nowhere to go. What we're actually doing is we create a whole different new exit right in front of you, right, so that you can get off the highway and get off this congestion.
And it works.
And it works. And patients do great. They have less follow-up, less eye drop. And in terms of the recovery, it's really something where probably the next day the vision's a little fuzzy, but by the end of the first week, all my patients are back to work, they're driving, and they just take some eye drops until the surgeries heal.
Okay, so I want to make sure I'm getting this. Okay, so glaucoma, which you lose your peripheral vision.
You got it.
It's caused by this water buildup in the eye.
Exactly.
That pinches or does something to the optic nerve.
Right.
So you start losing your vision. And then slowly the optic nerve dies and you can go blind.
Exactly.
So all these new technologies, including the drops, they just help with the drain, like Drano, you say.
Right.
So now you have lasers,
Yes.
you have surgical options to clear up the drain, and they get back to normal.
Right.
Really?
Yeah.
And so, but glaucoma patients aren't told this or all their options? What's your take on that? I know you want to be nice and polite on this program.
Right.
But it seems like a no-brainer here.
Right.
That if you have glaucoma, you've been given a diagnosis, that they are hearing about all these options.
Right. So I think what's so tricky is that because a lot of these technologies are newer, I would say in the last 10 years, a lot of doctors are still on a learning curve to try to learn how to do these technologies.
All right.
And I was fortunate enough that I was trained in this latest generation where I feel pretty comfortable with a lot of these minimally invasive glaucoma surgeries. And I do those equally in combination with some of the older surgeries that we're used to that are more invasive and require longer periods of healing. And that's what we want patients to know is that because there's now this paradigm shift and there's new levels of training and new generations of technologies available, you have to just ask your doctor what types of glaucoma surgeries you do, because not all glaucoma surgeons and not all ophthalmologists do the same surgeries, and they do them in different ways, and they don't do some of the latest technologies. So we want patients to be proactive and ask those questions.
So ask for a glaucoma specialist.
Yes.
That's fair to say.
That is for sure.
So not all so there's ophthalmologists that are treating glaucoma, but they're not a glaucoma specialist.
Right.
And it doesn't cost more to go to a glaucoma specialist. It's covered by insurance.
It doesn't.
Okay.
You're totally right. And some of the ophthalmologists feel comfortable maybe doing a laser, maybe they feel comfortable doing a stent, but about the 6 or 7 other glaucoma procedures that are minimally invasive out there, they're really not, they basically don't have all the background, just like I don't have all the background to do it with my retina or what my other ophthalmology subspecialists do. We're just very good at certain things, and because we do them more frequently, and that's better for the patient to go to someone who does those things.
Now you say this is life-changing. What do you mean by that?
So it's interesting. I have 2 groups of patients I see most often. I have patients who come to me and say, well, you know, I had an eye doctor tell me that I have glaucoma, and they think that because they have glaucoma, they're really going to go blind. I mean, I've had young patients in their 40s and 50s who think, I'm going to be on eye drops for the rest of my life. My life is going to be tied down to sitting down somewhere. I have to lie down. I have to put a bottle in my eye. I can't go out for more than 4 or 5 hours without running home and remembering to bring my eye drops. I mean, that is a huge time commitment. Some of my patients who are on 3 medications, they have to remember, did I take the blue or the purple or the yellow or the green? And they have to remember which one they just took and which one they haven't taken. It's a lot to keep track of, especially if you have 5, 6 other medications. So I've had one lady, for example, she's in her 60s, very active. She has to take care of her grandkids, pick them up from school. She has schedules and errands and volunteer work she does during the day. And then on top of that, she was taking 3 eye drops because someone told her that her eye pressures were too high. So when I met her, she came in with a bag of eye drops, and she would say, you know, between all of my errands and all of my work, I'm trying to remember which ones I already took and which ones I haven't. Sometimes I get mixed up. And then every 28 days, I have to call the pharmacy for a refill. And then on top of that, my copays are over $100 every month for these 3 eye drops. And I looked at her, I examined her eyes, and I said, gosh, your risk for glaucoma is really, really low. I would say less than 1%. Now, do we really need to take all those eye drops? If your risk is so low and your eye pressures are just borderline high, we can probably start taking you off and just seeing what happens to her eye pressure. And you know what happened, Randy?
What?
I took her off 1 drop at a time, and by the time we took her off 3 eye drops, her eye pressure barely went up a little bit. She didn't need to be on all those eye drops. For years, she had been tied down to these eye drops thinking, I have glaucoma because I have high eye pressure. This is my only choice.
It's interesting. So you're forced to take these $100 a month copay eye drops because you don't want to go blind.
Exactly. You're scared, right?
So there's a big motivation to take the drops, but you're here to say that maybe you need a second opinion. If you're on drops, see and I don't want to put words in your mouth, a glaucoma specialist.
Right. You just need to get someone else to take a fresh look at your eyes with their eyes and say, is this really medically necessary? Because if in that discussion you find the risk is so small and you're willing to accept that risk, which we take risks every day just driving down the highway, if that risk is really, really acceptably small to you, you may not need to be on 3 eye drops. So I've had other patients, for example, I had a lady who was actually on an eye drop that she'd been taking for years, and some of the side effects are they cause the eyelashes to grow, and so she had these horribly long eyelashes that for some people would be great, but hers were actually churning in, would constantly scratch her eyes, and she felt like she had something in her eyes all the time. She was going to her eye doctor every 3 weeks to get her eyelashes plucked because she had to be on these eye drops, she thought. And it was bothering her so much because you always feel like there's something in the eye. And she also had these sunken eyes. She said, you know, it must be part of aging when she saw me. The eyes looked like they had sunken into her head, but they were actually a side effect from her medications. Her eyes were completely red, irritated, and they were sunken as if she had cosmetic surgery.
So what did you do?
So I told her, I said, you know, because you're only on 1 eye drop, we can actually do a laser. And she said, what is that? And I said, outpatient procedure, 5 minutes, no recovery, you go home the same day, and we can get you off an eye drop. And she was amazed. We did the laser for her, and within 3-4 weeks, her eye pressure had dropped, and she got off on her eye drop. She didn't need it anymore.
So the laser actually cleaned the drainage part of the eye.
Exactly.
Pressure goes away, no need for the drops.
That's it. It's a very simple balancing equation, and that's why we want patients to check out this option, because having an eye drop may seem like an easy thing. It's maybe once a day, but the side effects can be even worse.
But if it's $50 or $100 a month, and it's causing side effects, may not be the way to go.
It really isn't for a lot of patients.
And the same thing with the surgery patient, where you create like an additional drain.
Exactly.
Those patients also can get off the drops sometimes.
Exactly.
Is that right?
Yes.
And they see better. Do they see better?
Yeah. So one of the problems with eye drops, that when you take them for a long time, they cause burning and irritation. And most of my patients actually tell me that once they put it in, they actually can't see sometimes for a few minutes because the blurriness from the eye drop can distort their vision. Some patients don't drive for 20 minutes, 30 minutes after they put the drops in. If you do that 3 times a day, that's a huge time commitment. So by putting in a small drain or a small stent in the eye, it's a surgery. Yes, you go to an operating room. Yes, it takes 2 hours to do from beginning to end. But after the surgery, if you've been on 3 eye drops and you go down to 0, which I've had in several of my patients, it's really life-changing.
And what about marijuana? Marijuana is supposed to bring down, medicinal marijuana is supposed to bring down the eye pressure.
Exactly.
People are doing this across the country.
Yes, yes.
This works? Effective?
It works. But how effective it is a big, big question mark. So think about 1 eye drop, and we've done studies actually comparing that 1 eye drop to how effective is marijuana to 1 eye drop. And you literally have to smoke the equivalent of 5 joints to have the equivalent of 1 eye drop.
So 5 of the marijuana joints is equivalent to 1 drop.
1 eye drop.
Interesting.
And if you're taking 3 eye drops a day, you do the math, that's 15 joints a day. And that's pretty hard to sustain.
So it's probably not helping your glaucoma, but you're feeling better and you're relaxed and don't worry about your problems, I guess.
Exactly. So maybe in that standpoint, you're not.
So marijuana's out for glaucoma.
I would say that at best it would be a supplement, but depending on where you get it, what your distributor is actually packaging for you, you're not really even sure that you're getting the right ingredient inside the marijuana to lower your pressure.
We are literally out of time. We have about a minute left. But I know in the green room, I said, you know, what's your main message? You said, well, there's 3 people, and I'm paraphrasing you slightly. The gray zone of diagnostics, people that are on tons of meds, and people that aren't responding to treatments.
Right.
That you want to help the most.
Right.
So if you can, a word on those 3 categories of patients.
Yes. So we want these 3 groups of people to be especially aware that they can come in to see us. 1, the people who've lived in glaucoma gray zone forever. They've been told by one provider or another provider they have it, they don't have it, they have it, they don't have it. They're back and forth. Or they've been told that, you know, you may have it, why don't you try these 3 different medications? They don't know whether or not they actually have it, and sometimes they don't have access to diagnostics.
They tell you this on the consult? Like, I don't know if I have it or not.
Right.
One guy said I had it, the other one said, don't worry about it.
So commonly,
Randy.
So commonly. And it's very frustrating when you don't know if you have something, if you don't know what your options are, and you don't know what your future is, right?
Okay.
So sometimes you just need to know, what is my risk? And sometimes it's an objective number. I can tell you you're at X% risk of developing it. And that is something that patients need to know to be able to empower themselves to take care of their eyes. The second group of people are people who are on a lot of eye drops. So most of my glaucoma patients at this point are maximum 2. Those are the patients who have some problems with surgery or can't go to surgery for other medical reasons. But really, if you're really on more than 2 medications, you need to see a glaucoma specialist.
Get a second opinion.
Get a second opinion,
Okay.
because that's a huge quality of life issue.
And the third?
And the third group of people are those who've been treated for glaucoma for many years, and they've been told by their eye providers that their glaucoma is getting worse. The problem is that those people often think that this is hopeless. This is my lot in life. I'm just going to have to be able to
Slowly go blind.
Slowly go blind. I'm going to give up my driver's license. I'm not going to be able to do this activity. I'm not going to be able to play tennis because I can't see the ball.
So you want to see those patients?
We want to see them because there's actually so much more new technology available now.
Okay, good. We're great stuff. So I think the main message here, it's like anything else. The public doesn't know that there's a subspecialty in ophthalmology, a glaucoma specialist.
Right.
Fellowship trained glaucoma specialist.
Right.
And they don't need a referral.
No.
Insurance covers what you do, Medicare covers what you do
Right.
to see a glaucoma specialist.
Yeah, you just have to pick up the phone.
Seems easy. So they could go to your centers and get a diagnostic workup.
Easy.
You guys do it all right there.
Yeah, and we can get you in within a few days. We really pride ourselves on getting you in and having them be able to sit down and chat with you about what it is that's important to you and how can we help you maintain that.
Now, I don't even think I'm paraphrasing here, but you told me on the phone, it's a great time to have glaucoma.
It is a great time. 20 years ago,
Because of what you could do?
Exactly. 20 years ago, we didn't have this. And now there's just this new whole wavefront of technology. Probably in the next 5 years, there will be more and more. And to have glaucoma now is completely a liberating experience in terms of you have choices that maybe your parents or your relatives didn't have. And that's why we want to hear from you and talk to you about.
Okay, good. I want to thank you for coming on the program.
Thanks
very,
so much,
very good.
Randy. Appreciate
Thanks.
it.
You've been watching The Wellness Hour. I'm Randy Alvarez for now. I wish you good health.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.